Acute respiratory failure is defined as a sudden onset of not enough oxygen passing from the lungs into the blood. Acute respiratory failure is rarely documented in its entirety in the medical record. Clinicians usually document the signs and symptoms of respiratory failure accurately, but do not often make the correlation between the symptoms and the documented disease. Acute respiratory insufficiency is often documented instead of acute respiratory failure. Querying for acute respiratory failure can be difficult due to the fact clinicians do not agree upon the clinical indicators of the disease. Some clinicians believe a patient must be on mechanical ventilation for the patient to be in acute respiratory failure. Other physicians do not agree. It is best case scenario that the CDI department you team up with has a baseline of common clinical indicators acceptable to warrant a query for acute respiratory failure. Nursing documentation tends to capture the more visible symptoms such as grunting, poor gag reflex, stridor, tachypnea, cyanosis, and use of accessory muscles. Stridor is a high-pitched breath sound which is caused by a narrowed airway. Grunting is a noise made on exhale. A healthy gag reflex prevents items not intended to be swallowed and helps prevent choking. Patients with poor gag reflex are at high risk for aspiration, which can cause acute respiratory failure if aspirated item becomes lodged. Tachypnea is abnormally rapid breathing at rest. The average adult breathes 12 to 20 beats per minute. Tachypnea is often defined as breathing more than 20 beats per minute. Cyanosis is a change in skin color to blue or purple. This can be caused by low oxygen saturations. Accessory muscles are muscles used during exercise to assist in forcing respiration. They are often quiet during normal breathing. During respiratory failure, the patient may start using the abdominal or neck muscles to assist in breathing. The nurse will notice abnormal movement in these muscles. Patients with pneumonia, sepsis, asthma, COPD, and heart failure are at high risk for developing acute respiratory failure. Patients who desaturate during a procedure may have a laryngospasm. A laryngospasm is occlusion of the glottis. Some patients have laryngospasms due to anesthesia. If you are considering a query post-operative respiratory failure, the patient should have been weaned from supporting oxygen and oxygen therapy was reinitiated, or the patient was weaned to very low levels of oxygen support and the oxygen level was significantly increased. If the patient is intraoperative and shows clinical indications of acute respiratory failure, consider adding to the query acute respiratory failure due to anesthesia. If patient has abnormal physical signs and symptoms, an arterial blood gas lab exam will be performed. This is a blood test which measures the amount of oxygen and carbon dioxide in the blood. PaO2 measurements of blood gas values, PaCO2 measurement of carbon dioxide, SaO2 measurements of oxygen saturations, pH measurements of acidity. A pulse oximetry test is a non-invasive test used to measure a patient's oxygen saturations. It is a monitoring device most commonly placed on a patient's fingertip. The pulse ox reading is an SpO2 reading, which is saturation of peripheral oxygen. A normal SpO2 range is between 95 and 99%. Patients with respiratory disorders often undergo a chest X-ray or a CT of the chest to look for clinical conditions which might cause the respiratory distress. Pneumonia, emphysema, lung neoplasms, atelectasis, pulmonary edema, and pleural effusions often cause impaired breathing. ICD-10 bundled hypoxemia and hypercapnia with acute respiratory failure. Hypoxemia is a decreased PO2, which is decreased PaO2 or SpO2 with normal PaCO2 and normal pH. Hypercapnia is increased PaCO2 and decreased pH level. Each clinicians have different acceptable ABG and pulse oximetry measurements they accept when diagnosing a patient with acute respiratory failure. CDI programs have used industry references to support their queries. If your CDI program does not have an internal or industry reference, then the best case scenario is to base your query on treatment given. If a patient is placed emergently on mechanical ventilation or high levels of oxygen via nasal cannula and there is no diagnosis of acute respiratory failure, the clinical indicators should be reviewed. Emergent intubation with mechanical ventilation is the industry treatment for severe acute respiratory failure. Although a patient may be placed on mechanical ventilation if they are not in acute respiratory failure, but their airway is compromised or might be compromised. Therefore, the CDI coder should check for abnormal ABGs or pulse oximetries when querying for acute respiratory failure. Patients with respiratory conditions are often placed on nasal cannula. Nasal cannula is a device which delivers supplemental oxygen and increases airflow. The device is connected to a flow meter. Oxygen is then delivered by measured liters per minute. The higher the liters of oxygen per minute given to the patient, the more severe the respiratory condition is. Patients with asthma and COPD will have lower levels of normal oxygen saturations due to their chronic respiratory diseases. Clinical indicators for respiratory failure will be different in these patients than in patients with no pre-existing respiratory condition. Understanding the patient's respiratory status on room air when their asthma or COPD is stable helps when writing a query for acute respiratory failure. Then the CDI coder needs to be able to glean what the respiratory status looks like when their respiratory disease is in acute exacerbation. Acute respiratory failure clinical indicators will be more severe than that of a patient in acute exacerbation of their asthma or their COPD. Common clinical indicators of acute respiratory failure include apnea, asthma exacerbation, aspiration, lung injury, diffuse alveolar infiltrates of the X-ray, cyanosis, COPD exacerbation, dyspnea, grunting, acute heart failure, inability to lie fat, laryngospasm, nasal flaring, pneumonia, poisoning, a poor gag reflex, sepsis, shortness of breath, stridor, tachypnea, use of accessory muscles when breathing. Common diagnostic tests for respiratory failure include arterial blood gases, SpO2, PaO2, PaCO2, and ABG-PH. Chest X-ray, CT of chest, pulse oximetry, which includes the SpO2, and common therapeutic treatments of respiratory failure include cardiopulmonary resuscitation, BiPAP or CPAP, endotracheal intubation, high-flow nasal cannula, mechanical ventilation, repositioning patient to upright position or prone position, and possible query options for acute respiratory failure include acute respiratory failure with hypercapnia, acute respiratory failure with hypoxemia, acute respiratory failure due to anesthesia, acute respiratory failure due to drug overdose, acute respiratory failure due to heart failure, acute respiratory failure due to pulmonary embolism, acute respiratory failure due to pneumothorax, acute respiratory failure due to sepsis.